Finding Your Way with Ocular Melanoma. Join me, host Tara McCannell, as I share with you everything that I know about this rare cancer. I hope you will learn, get your questions answered, and be motivated to empower your own healing and to live your best life. Visit my resource page, sayhart.com/ocular melanoma. That's SEYHART.com/ocular melanoma for more content and support. There you will find my handbook, Finding Your Way with Ocular Melanoma for Patients and Families, as well as a host of other recordings, videos, webinars that I've done about all sorts of aspects of ocular melanoma. Today, I'm going to talk to you about how do I treat a choroidal melanoma? Why is choroidal melanoma so challenging? It's because it is such a rare cancer that most ophthalmologists have never seen one before in their career. And when something is so rare, it can be difficult and challenging to make the diagnosis. So the very first part about treating a patient with choroidal melanoma is ensuring that we have the correct diagnosis. Diagnosing ocular melanoma, choroidal melanoma, uveal melanoma, they are all essentially the same eye cancer, is based on what we call a clinical diagnosis. And what is a clinical diagnosis? When someone says there is a clinical diagnosis, it means we use all of our experience seeing patients over many years that have this condition to help us recognize that this indeed is an ocular cancer. In addition to our clinical evaluation, which is the real life in-person exam, we also use a variety of imaging studies, photos, scans, ultrasound, and all of these tools help confirm that it is indeed an ocular melanoma. We don't have any imaging test that rules in, or if the test is positive, for sure it's a melanoma, because all of these imaging tests can look so many different ways. And that is part of why it can be challenging to make the correct diagnosis. Lately, it has become more popular to perform a prognostic biopsy on a suspicious choroidal mass. What does this mean? This could take the form of this encounter. Your doctor looks in, not totally sure it's an ocular melanoma, and says, let's take a biopsy and we'll send for some genetic markers that we see, because prognostic genetic markers can be either low risk or high risk. And if you have a low risk marker, then we won't treat you. If you have a high risk marker, then we will treat you. It's really important to know as a patient that these markers, these genetic tests, these prognostic tests were never validated for making a diagnosis. They were validated to be used when we already know that the situation is an ocular melanoma and we're giving additional information to the patient about the nature of their cancer. However, nowadays, because there are so many people who are practicing ocular oncology who may not have years of experience, there's a little more uncertainty. And so doing biopsies when we are not sure is becoming rather trendy. Again, I have said in past episodes and videos that I've done that it is so important to get a second opinion. It is important to get a third opinion. You need to have a set of eyes on your condition that has seen this before and is basing your evaluation on the memory of thousands of patients that have come in with suspicious masses of the eye. So the most difficult part, in my opinion, of treating a choroidal melanoma is making the correct diagnosis. And because a lot of times patients come into the office, they don't know about this. They've never heard of this. And they just take their doctor's word for granted. If you have any gut feeling that you're not sure, or you didn't really like how things were explained, I urge you, get a second opinion. People always get second opinions when we're dealing with a rare disease. Don't even consider the feelings of your ocular oncologist. If my patients want a second opinion, I will help them get second opinions quickly, especially if time is of the essence. Our job is to help you get through this. And if you need more set of eyes, you need more experience, you want another doctor to see you, so be it. Medicine and caring for these diseases is about the patient. It is never about the doctor. So let's go back to how we treat choroidal melanoma. Luckily, these days, we are able to diagnose ocular melanoma when the tumors are not that big. And that is because we have so much photography, photo screening that occurs in various optometric offices. I would say that over the past 15 years, we have found so many asymptomatic small ocular melanoma because of these tests. And the benefit of early detection is that our treatments are less severe. We use less radiation and there are fewer side effects, and people do overall so much better, not only from the vision standpoint, but from a mortality standpoint. The smaller the melanoma is at the time of diagnosis, the lower the risk that it might metastasize or spread in the body. However, sometimes the melanoma is so big that vision has been poor for quite some time. And in these cases, I always recommend that we move ahead with eye removal or enucleation. If the eye isn't giving vision and we try to radiate it more to kill the cancer, we end up with an eye that is not only blind, but can usually be very painful, sore. It necessitates a lot of visits. And what is the eye giving back? So, if the situation is not hopeful for any function, I do think considering eye removal or enucleation is a good potential option. Now, when we treat melanomas of the eye, the most common way to treat these is with radiation. We have by far the most experience using radiotherapy. We know that radiation will kill cancer. Treatments like laser and others that don't involve radiation may be more gentle on the vision, but at the end of the day, they have a higher rate of recurrence because we didn't destroy the cancer. I think radiation is a phenomenal treatment, and if we can treat early and be preventive and proactive, we don't have to use as much. There's another thing that we do here at the University of California, Los Angeles, in our Ocular Oncology Center. We use silicone oil to act as a radiation shielding substance. How does this work? The vitreous humor, which is the fluid inside the eyeball, is essentially water. When we put a radiation plaque on the outside of the eye to kill the melanoma, there will be some healthy tissue that gets affected and damaged by the radiation. If we can fill the inside cavity of the eye with a substance that is denser than the water, such as silicone oil, which we have used for many years for retinal detachment repair, we can reduce the radiation exposure to healthy tissue. At our center, we have demonstrated that this technique improves vision, reduces radiation retinopathy, and we get far fewer eyes with no light perception or light perception. So we are essentially able to reduce blindness if we can use some of these techniques to reduce radiation at the onset. There are people who say, well, we don't really need to do that because we have all of our injections, the Avastin, the Lucentis, the Eylea that we can give to treat radiation retinopathy. Yes, it's wonderful that we have these treatments. However, once tissues and DNA have been damaged by radiation, they do not regenerate, though they do not come back. So these injections can temporarily prop up the damaged vessels, but at the end of the day, Avastin, anti-VEGF drugs, steroids, they don't repair and regenerate damaged tissue. So it is only a temporary fix, but it still may be beneficial. I definitely embrace using these injections, but it's important to realize that the injections are not going to save the eye. They are sort of an adjunct therapy to help give people the best chance for vision. Now, what do we do after radiation treatment? It is important to follow up with your ocular oncologist. Why do we do this? We always want to make sure that the melanoma is killed, stays treated, and is responding well to radiation therapy. We want to make sure that if we ever see signs of recurrence, meaning it's starting to come back, we catch that early so that we have a lot of options. Many times we can retreat with brachytherapy plaque if the tumor starts to come back. We always want to know this. In addition, we want to monitor carefully for side effects of radiation. I mentioned using the anti-VEGF injections, but also there are times when the perfusion, the blood supply to healthy parts of the eye may start to deteriorate. And when we catch this early, we can apply pan-retinal laser photocoagulation. If we're not seeing non-perfusion, patients don't need additional laser. But if we start to see non-perfusion or perfusion problems because of the radiation, we can catch this before it gives symptoms and apply laser photocoagulation treatment. I encourage you to look back. I did an episode all about pan-retinal laser photocoagulation in the past. So one more thing we have to always check when you're getting these follow-up visits is your other eye. So many times I find that everybody is zeroed in on the eye with the melanoma that they forget about a lot of common things that can happen with the better eye, such as cataract, glaucoma, macular pucker, retinal hole. There's all sorts of things that are far more common than ocular melanoma. And I find that the treatment of these common things in the fellow eye is often delayed, not only because of the attention that is shifted to the melanoma eye, but also there is a fear for doing any surgical procedures to the good eye. And I think this is ridiculous. Today in 2025, we have such incredible vitreoretinal surgeries. We have such advances in cataract surgery. We want the fellow eye to benefit from anything that is going to help it see its absolute best. We don't want to be holding back on surgical procedures. These are things that are so straightforward that unfortunately a lot of patients don't get access to basic ophthalmic care. So I hope you keep these things in mind. When you see your ocular oncologist, when you see your ophthalmologist, you want to know what's going on with everything in your vision. I hope this was helpful. Thank you.